Good afternoon, everyone. My name is Grace Warkulwiz, and I am a junior at Penn State University studying biomedical engineering. Unfortunately, I was not able to attend the conference in person today because I am currently in Kenya working on a project for the Humanitarian Engineering and Social Entrepreneurship program at Penn State. So I hope you all enjoy this unique presentation of my paper that focuses on the importance of interactive small group discussion to educate community health workers. So I have been involved in the Humanitarian Engineering and Social Entrepreneurship program, often referred to as HESE, for the past year. HESE integrates learning, research, and entrepreneurial engagement in order to prepare students for careers in social entrepreneurship and global development. All of the HESE ventures address global development challenges. Half of our ventures are focused on food security issues, while the other half are focused on health. These ventures all fall under the umbrella of Mashavu, which is a networked system based in Kenya that provides accessible pre-primary health care to developing communities. Mashavu means chubby-cheeked in Kiswahili, and we hope that all of those who receive our services will one day have chubby cheeks as a sign of healthiness. The lack of doctors and nurses in developing countries makes it difficult to care for the growing population. Local community health workers have stepped in to bridge this gap between patient and healthcare professionals. Now, Mashavu is a unique system in that it employs community health workers who would otherwise be volunteers to the community. We are a cash-positive venture, and we currently employ 6 CHWs who are providing health services in Neary County. We have focused a lot of our energies over the years on CHW training and education. Mashavu also works to provide low-cost medical devices for the rural Kenyan community. I am currently working on a project of creating these UTI screening test strips. The beauty of this product is that they are made using a standard inkjet printer. The idea of inkjet printing technology can be applied to screen for additional diseases as well. We aim to become a for-profit company and sell these strips to the local communities. So at HESE, we design with communities and commercialize for markets. So now that I've given you all a little overview, let's come back to the main focus for today, CHW education. Developing countries, particularly those in Africa, have taken on what has been called a double disease burden, meaning that they lack the proper resources and funding to address challenges related to both infectious and non-communicable diseases, such as cancer, diabetes, and cardiovascular disease. There is ample evidence that the double disease burden in developing countries can be mitigated with help from community health workers. As I mentioned before, CHWs are becoming extremely important in resource-constrained environments because they bridge the growing gap between patient and doctor. CHWs are trusted volunteers selected by their local community to provide basic primary health care. They provide their communities with education on basic public and environmental health, as well as first aid treatment. Since CHWs are part of the communities they serve, they share many characteristics with those they are helping. This includes language, socioeconomic status, and ethnicity. This enables CHWs to convey health information using the local language and value systems, putting it into the context of the community. However, to do all of this successfully, CHWs must be properly trained. But there is a problem. Many CHW programs are proving to be ineffective. Why? Because they severely lack adequate training regimens that standardize the playing field and offer equal services and information to community members they serve. Current CHW training, first and foremost, does not have a consistent methodology. There are many variations in the organization, length, and complexity of the training depending on where it is taking place. Many developing countries do not have the funding and resources needed to train CHWs properly, creating inadequate training regimens. Many CHW training sessions in rural contexts have relaxed settings, leading to informal training where many CHWs are venturing out into their communities without the proper educational background. The training that the government suggests and the training that actually occurs in developing countries varies greatly. For example, in Kenya, the Ministry of Health requires CHWs to undergo 2 weeks of training followed by regular refresher courses. Unfortunately, many CHWs have not received either of these due to a lack of funds and resources. So instead, they rely on informal training. Therefore, the lack of standardized training methodology in current CHW programs in the developing world is posing a huge problem. The World Health Organization suggests several parameters for CHW training programs in developing countries. These include methods that require few resources, short implementation, and are simple. It also suggests the use of interactive sessions in order to reach less educated or illiterate CHWs. However, according to the literature that we have looked into, a program incorporating all of these parameters has yet to exist and be implemented. So meet my team. I'm on the left and my co-author Laurel Paul is on the right. We strategized on creating a standardized training method for community health workers in Kenya. We compiled our project over a semester-long period here at Penn State, and we were able to travel in conjunction with the Mashavu Venture to Nyeri, Kenya last May, where we conducted our study on the ground. So our main research question was to look into which interactive method worked best for the CHW context. So we created 3 different methods of training. One was a demonstration, another was a hands-on method, and the last was a group discussion. So while in Kenya, we were stationed in Nyeri, which is about 3 hours north of Nairobi. We partnered with the Kenyan Ministry of Health and we traveled to local dispensaries in 4 surrounding villages. While we were there, we conducted the training sessions we had developed over the semester to local CHWs. We trained 104 CHWs total through our training sessions. We created a simple PowerPoint presentation to show, which covered the topics of diabetes, cancer, and cardiovascular disease. The main focus of our project, though, was the interactive activity which we developed for the CHWs. After the PowerPoint, the CHWs were split into 3 different groups and the interactive activity was introduced. The first was a demonstration where the activity was led in front of the group by one of the Penn State presenters. The second was a hands-on experience where every member of the group actively took part in the activity as they were led by another Penn State presenter. The third method was a group discussion where the CHWs were broken up into smaller groups and worked with each other on the activity, which also was led by a Penn State presenter. An 8-question pre- and post-test was administered to each participant in order to gauge the amount of learning that occurred during the training sessions. Our interactive activity was a model of what happens to the cardiovascular system during cardiovascular disease. We took a plastic cup, which represented the heart, and inserted a small hole and a straw, which represented an artery. Water was poured into the cup and came out of the straw freely. Next, we took Play-Doh, which represented plaque, and we clogged up the straw. So when the water was poured into the cup, it no longer came out of the straw, demonstrating cardiovascular disease. So here are some of the slides that we gave to the CHWs during our training sessions. It was really important that we brought in the Kenyan culture. So as you can see here, Karibu Sana was our opening slide, which means welcome. We also depended a lot on visuals and graphics. And we also took a look into using hand motions in order to convey the information more clearly to the participants. So here is one of my team members conducting a training session at one of the dispensaries. The PowerPoint was projected onto empty walls using just a portable projector that we brought with us. So from conducting our presentation, interactive activity, and pre- and post-tests, we were able to conclude 2 main things. The first is that all 3 methods were successful tools for teaching the material to the CHWs in this particular context. The second result was that the data amongst the 3 methods was not significantly different. Therefore, no specific group of either the demonstration, hands-on, or group discussion performed better than the rest. All 3 methods are equally ranked as equal teaching methods according to our data. So what exactly can we take from this experience? Our results suggest that the structure of simple, picture-dominant presentations are viable for presenting the health information CHWs must learn to perform their tasks. This method is ideal for resource-constrained environments because the presentation itself requires few supplies, making it simple to incorporate to improve CHW job performance. The second is that each breakout group demonstrated an increase in scores between the pre- and post-test, indicating that interactive breakout groups can be useful aids in the training process because they highlight important topics in great detail. Because no specific score difference was found between the breakout methods, any of these educational methods can be chosen to convey information more effectively when designing CHW training regimens. However, the demonstration method is probably the most effective tool in low-resource environments because it requires the least amount of supplies and still engages the participants. There is ample evidence out there that CHWs can help close the gap between patient and doctor in developing countries. However, in order to do so, they need the formal training in different health topics. Yes, we can conclude that the technology and active methodology that we created proved to be helpful in this process. However, the real game changer in these situations is the conversation and the interaction. It is imperative that CHW programs begin to invest the time and money in order to give trainers the opportunities to have these conversations with CHWs. Without these small group interactions, CHW programs around the globe will continue to have various degrees of success. So that concludes my presentation for today. I thank you all for your time, and I am actually available via Skype to take any questions that you might have. Also, feel free to email me. My email is shown here on the screen if you have any additional questions that can't be answered during this time. Thank you.